Okay, so now we'll quickly do the thalamus nucleus. Main thing here is going to be, wait just a second. The main thing about this is basically this will come as a match the following mostly. Okay, so the ventroposterolateral. Okay, this is very well given in pixelized. Okay, so you can see that image as well. The ventroposterolateral nucleus located in thalamus. It receives from dorsal column obviously, and from even the spinothalamic tract, and it is mostly a sensory. Okay, it sends to the primary sensory cortex, and it is ventroposterolateral nucleus. Next is ventromedial nucleus, is the trigeminal. So three gems, trigeminal, and looking at this thing, gustatory, mainly the gustatory, and it's supposed to be posteromedial nucleus. Okay, Pixelrize has a very good annotation for this. Next is sensory relay, sensation from the face. Okay, obviously trigeminal is going to be sensation of the face, gustatory. We just saw the previous that it provides sensation to the anterior two-third of the tongue. Okay, because the anterior two-third of the tongue is coming from the first pharyngeal arch. Okay, and posterior two-third was what? It was glossopharyngeal, both sensation as well as taste. Okay, next we have primary somatosensory cortex. This is okay, and obviously sensory relay. Next is the lateral. So lateral geniculate, everyone is lateral is for the optic chiasma, and everything, and medial is for the superior inferior olive and the hearing. Okay, colliculus, inferior tectum, and all that. Next is and obviously it goes to visual cortex, and that one goes to the auditory cortex. Next is ventral ventral anterolateral. Okay, so ventral anterolateral. Okay, or ventrolateral. Okay, this is supposed to be from the basal ganglia and cerebellum. Okay, basal ganglia, cerebellum, that is this thing. So ventral and lateral, ventral anterior lateral, that is from the cerebellum, basal ganglia, and it goes to the obviously cerebellum, basal ganglia will go to the primary motor cortex only. And yeah, I think it's fine. Okay, and yeah, just remember olive and this thing. So the sleep part that we did have, and one more thing about the this thing. So we have that ghrelin, leptin, all that we went through, right? And appetite. So yeah, that was pretty simple. So another thing is anterior is also cooling. Okay, so cooling of the body is also anterior. Okay, and yeah, the posterior nucleus. So posterior nucleus was heating. Pre-optic, pre-optic, you'll get a very good pixelized representation. That sexual behavior, gonadotrophin release, and thermoregulation. Okay, so yeah, you can see that. All right, and yeah, I think we're good to go. Okay, so this is done. All of this is done. It relays consciousness. Now we'll come to the limbic system. Okay, and the most important part for this is basically this region. Okay, this is more important for the psychiatric drugs and all. Okay, so you'll get that, like bits and pieces psychiatry mein there is. Okay, this part ki positive symptom where, negative symptom where, and everything. Okay, so let's see. Collection, limbic system, obviously collection, neural, it is emotional. This is not why this thing. What's the hippocampus, amygdala, mammillary bodies? Okay, so yeah, this is important. Okay, so limbic system, hippocampus, amygdala. Okay, you can see here A is the hippocampus. Okay, then is the amygdala, mammillary body, anterior thalamic nucleus, cingulate gyrus. Those are the yellow. Okay, and this one, the red arrow is hippocampus. This is hippocampus, this is a cingulate gyrus. It comes from top, no? Entorhinal cortex, responsive for fleeing, feeding, fighting, feeling, and sex. Okay, and you have amygdala, mammillary body, anterior thalamic. Okay, So all this is done. Next is dopaminergic pathways. So this is quite this thing. Oh, and this is also important. Fornix is an association fiber, okay, and it is an anterior cerebral artery, and it connects the hippocampus to the midbrain. This is a previous year question. Ki fornix connects what? So fornix connects the mammillary body. Okay, fornix connects the hippocampus to the mammillary body and anterior cerebral artery and fornix. These are association fibers. Okay, antecedent sagittal section of the brain, association, hippocampus, anterior cerebral artery, and these. Okay, this is mainly important in case of your this. Okay, like this part is mainly important in case of psychiatry. So we'll just quickly go through this. Actually, in the background, like Pixarize has some really good images for this. Like now see, how is this table important in psychiatry? Okay, obviously drugs commonly altered by drugs and movement disorders, your Parkinsonism. But this has a lot of utility in schizophrenia. Okay, so see, we are doing neuro, but actually we'll be doing neuro, eye, ear, eye, ophtha, ENT, and even this thing, your psychiatry to some extent, okay, along with this neuro, because I'll try my best to do as much neuro as possible. Okay, so the first thing is mesocortical pathway. Okay, so mesocortical pathway, in this you have, okay, so mesocortical pathway, what happens, if this is what, this is mainly what, okay, so you have to correlate schizophrenia. So it is involved in cognition, it is a dopaminergic pathway, okay, and it is involved in motivation, emotion, okay, and it connects the cortex. It means it goes from the cortex to the midbrain, okay, means it connects the cortex and the midbrain. All right, so cortex and the midbrain, it is connecting. Mesocortical, always remember mesencephalon. Okay, so all these meso structures, they all midbrain, okay, and mesencephalon was giving rise to the midbrain, your aqueduct of Sylvius. Okay, so mesocortical. Okay, so mesocortical we know now is going to connect the midbrain and cortex. Okay, so it is involved in what, cognition, it is involved in motivation, emotion, okay, and these are dopaminergic pathways, so that is fine. What happens schizophrenia mein, it decreases. Schizophrenia and psychotic disorders, it is inhibited, and because it is inhibited, it causes the negative symptoms of schizophrenia. Okay, so what happens is, when do we say negative? Negative is when something that was there, like we as normal human beings, we as human beings, we do have motivation, and we have cognition and all of that. So cognition, motivation, all of this is taken away, okay, is minus. So we get apathy, we have apathy, lack of spontaneity, and we have anergia, all this stuff. Okay, so that is why, the reason why I'm talking about this is because this will help in antipsychotics. Okay, so that's why we have mesocortical. Okay, so mesocortical is done, and mesocortical, it is inhibited and it causes negative symptoms. Okay, next we have is mesolimbic. All right, so mesolimbic, we've got mesolimbic. Okay, so mesolimbic, in case of mesolimbic, what we have, it is a dopaminergic pathway, and it obviously connects the limbic system to the uh, midbrain. Okay, because we are seeing it from the name only. So mesolimbic is going to be for the positive symptoms. Positive symptoms is something that is added. Okay, means something that was not there, it newly comes up. Okay, so that is delusion, hallucinations, and so on. So when this is inhibited, then you have a lot of this thing. You have when this is increased, basically activity when it's increased in schizophrenia, kind of like mania. Okay, so you'll have more of delusions and hallucinations, the positive symptoms, because of this. Okay, so one more thing, this the mesolimbic, it's a reward pathway. Okay, so reward pathway, mesolimbic is going to be reward pathway, and obviously, okay, so reward pathway, and when it is increased, like when it is the activity of this pathway is increased, it basically gives rise to the positive symptoms. Next is nigrostriatal pathway. So nigrostriatal pathway, it is the extramedullary pathway, and okay, nigrostriatal pathway was obviously your Parkinsonism. It is damaged and it connects, basically connects the, it is a component of basal ganglia, or it connects the striatum. Okay, striatum and the substantia, nigrostriatal, right? So nigro means nigra, substantia nigra, and striatal is striatum. Okay, so that connects the basal ganglia, and obviously it causes Parkinsonism. And what happens is it decreases. Okay, like when it's damaged, causes Parkinsonism, it decreases in case of EPS. Okay, it decreases in case of EPS. Okay, so like it is inhibited. Okay, you have extrapyramidal side effects, all the dystonia, akathisia, Parkinsonism, tardive dyskinesia, and all that it causes. So basically now you can correlate this. Okay, not only does all these features, okay, your all these features of nigrostriatal pathway happen in Parkinsonism, but it will also happen with haloperidol and you know, chlor this thing. Okay, so your chlorpromazine, okay, all the yeah, typical antipsychotics, okay, that basically high potency, especially the high potency antipsychotics, that will decrease the action of all these. So yeah, that is very understandable. Next is the tuberoinfundibular pathway. So tuberoinfundibular pathway, obviously when that decreases in activity, you tuberoinfundibular, so that is basically all the prolactin stuff. Okay, so in tubero and fundibular. Tubero is basically the pituitary, and fundibulum is the part of the pituitary that is connected to the hypothalamus and so on. So it increases in activity. If this decrease in activity, obviously you'll have more of more prolactin. Okay, and then after it, decrease libido, because prolactin causes galactose, decrease gynecomastia, and so on and so on. Now, most important, tubular and fundibular pathway you can forget, but these three are very important. Okay, your antipsychotic drugs, they have very limited effect in case of mesocortical. That is a negative, something that you're taking. But then, in case of primary target of all the antipsychotic drugs is to decrease the positive symptoms of schizophrenia. Okay, and obviously this is major this thing, not only antipsychotics but also movement disorders in both. Now you will go back to this thing. If you go back to you know, if you go back to that particular table that we had. Okay, now again look at this very carefully. Mesocortical, there is decreased activity. Okay, but mesolimbic, there's increased activity, so the person very emotional, reward system is working at fullest. Okay, so we will just go back to that particular table where they had all the neurotransmitters. Okay, now the reason why I'm wanting to go back to that is because then it will give a final clear picture of everything. Okay, then we can have a yeah, this neurotransmitter. Okay, then we can have a final clear picture of everything. Okay, so just a second. Okay, so let's see, उसमें what was there. See, in Parkinsonism, though we were having this, but in case of schizophrenia, what were we having? Okay, see, prefrontal is decreased. Prefrontal is decreased as what? Mesocortical pathway it is decreased. Okay, while mesolimbic pathway it is increased. Okay, they told more about the mesolimbic pathway. So they were meaning about they were trying to in first aid they have written just increased. Okay, increased where? That is the subcortical pathway. That is the mesolimbic pathway. That is the reward pathway that causes hallucination and delusion. Mesolimbic pathway. But what about this? Okay, so that decrease happens in the mesocortical pathway. So that's why this table is important, and now the connection also makes sense. Okay, so that is that. Depression where everything is decreased, anxiety norepinephrine is increased, and yeah, and mesocortical mesolimbic that we have already spoken about, and this table is also done. Next we come to cerebellum, very important. Okay, like I can't estimate the number. I mean, they keep giving this. They give Purkinje cells ka histology and so on. Just a second. Okay, now let's come to cerebellum. Okay, so cerebellum extremely important. Okay, so let's see. Okay, cerebellum. Every word, every line, extremely important. Okay, so modulates movement. Okay, so cerebellum modulates aids in this thing. Ipsilateral unconscious proprioceptive information via inferior cerebellar peduncle. So ipsilateral. Cerebellar lesions, obviously they are anyways, they are usually ipsilateral. So ipsilateral unconscious proprioception, okay, that is going to be cerebellar peduncle. Deep nucleus lateral to medial DEGF, dentate emboliform, globose and fastigial. Okay, so DEGF alphabetical order, lateral to medial. Okay, so this is very important, lateral to medial. Okay, next is lateral lesions. They affect voluntary movement, lateral structures when injured, the propensity fall towards injured side. Okay, obviously ipsilateral. Okay, so voluntary movements of extremities is lateral. Okay, so basically when we have a this thing, it is basically this is the way that the person is sleeping basically. So this is the way that the person is there, that is this part, this particular part is towards the lateral and this particular part is towards the medial. Okay, so that is the trunk. So first, what do we have? Voluntary movement of the extremities, lateral structure. When injured, they have a propensity to fall towards the injured side, that is ipsilateral side. Okay, because that side has no balance. Okay, next is medial. So medial is going to be vermis, fastigial nucleus. So we had vermis here. We have the fastigial nucleus, that is the medial most. This was outer, lateral to inner. Okay, lateral to medial. Okay, next is we have the flocculonodular lobe. So flocculonodular lobe, small one here. All right. So this is truncal ataxia. That's why we have wide base cerebellar gait, nystagmus, head tilting. Generally results in bilateral motor deficits affecting axial and proximal limb musculature. That is the medial structures. Okay, because cerebral lesions are medial, so it's as simple as that. Okay. Next is, and obviously finger to toe and heel to this, heel to shin, and most importantly, that one, dysdiadochokinesis. Dysdiadochokinesis. Okay, so this is important. Dysdiadochokinesis. Alright, this particular term, dysdiadochokinesis. Okay, so now we'll do input output and then finally we'll do input output. See, medial, you can see input output, that is important. Okay, vestibular nuclei. Okay, inner nuclei, inner ear. Okay, inner ear is going to be the vestibular nuclei. Okay, inner ear, there's going to be vestibular nuclei, and then this particular middle part is going to be medial cerebellum. Okay, medial cerebellum. Okay, medial cerebellum, cerebellar cortex via Purkinje cells. Okay, so cerebellar cortex via Purkinje cells, we have the deep nucleus. Alright, cerebellar cortex via the Purkinje cells, deep nucleus, and superior cerebellar peduncle and contralateral cortex. So this is how basically you have the pathway. Okay, this is the outer output pathway and this is the input pathway. So let's see. Okay, each and everything we'll do and then we'll do this diagram. Okay, so first is cerebellar input. Okay, so you have all the proprioceptive information. You have the inner ear ka vestibular nucleus that is coming to the flocculonodular lobe. Alright, next we have what happens, proprioception. It comes from the spinal cord via the inferior. See, middle cerebellar peduncle is contralateral cortex, okay, but inferior cerebellar peduncle is ipsilateral. Okay, so spinal cord proprioceptive information goes. Now after going, what happens? Inferior cerebellar peduncle. So when it goes into the this thing, so what happens? Let's see. Okay, so first what happens, here we have pons, we have the reticular formation, we have the spinal cord and with the vestibular nucleus. So just now we saw that from this vestibular nucleus inner ear ka information is coming, from the spinal cord you have inferior cerebellar peduncle. Okay, so these are excitatory fibers. Okay, and these are mossy fibers. This goes, so mossy fibers, what does it do? Okay, now first we have the layers of the cerebellum. This is cerebellum medulla. Okay, so this is medulla, and then we have granular layer. Okay, so medulla mein we have this cell, that is the deep cerebral nuclei, and we have the mossy fibers. In granular layer we have the climbing fibers going, okay, and we have the granule cell. The granule very easy, and the Golgi cell. Okay, so Golgi and G, okay, all G. Okay, granular Golgi and this. Okay, next you have the ganglion. Okay, ganglion. So ganglion will form a ganglion and form some kind of connection. So ganglion is basically Purkinje cells. Okay, obviously these are bipolar neuron. That's also one point to note. Next is molecular layer. Molecular layer has HNE mein, it is the palest layer, and it has got stellate basket cells, so astrocytes, basket cells, parallel fibers, and so on. Okay, so more or less fine. Now what happens to the connections and stuff? Okay, so let's see. Here we have, okay, so the fibers. Okay, so this was coming from inferior. It comes as ipsilateral, while middle cerebellar peduncle it comes as contralateral cortex. So yeah. Okay, so here we vestibular nucleus, this is going excitatory from the medulla. All right. So mossy fibers. Mossy fibers goes and stimulates two things. Okay. So mossy fibers. Okay. Everything is stimulatory. Okay. Everything here is stimulatory except this Golgi. Actually, everything looks inhibitory except this parallel fibers and little bit of this. Okay. So mossy fibers, this line. So mossy fibers is very positive. So it goes and stimulates this deep cerebral nuclei, and then it goes and stimulates the ganglion cells. Okay, so granule cells, ganglion granule cells. Okay, so granule cells. Now what does granule cells do? Now in case of cerebellar cortex, okay, everything is inhibitory except granule cells. Okay, granule cells is not inhibitory. Granule cells is excitatory because it gives out the parallel fibers in the molecular layer, which stimulates astrocytes, which stimulates basket cells. Now astrocytes, what does it do, and basket cells, what does it do? So astrocytes and basket cells, they are the enemies of this Purkinje cell. Astrocytes inhibits the Purkinje cells in the molecular layer, while basket cells, like slightly, see, astrocytes, you can think stellate cells. Astrocytes, these are like stars. Stars will always be high up in the sky, so it is not coming here. And basket, we put the basket down, so that's why this is going here. Okay, this can be a mnemonic like this. So Purkinje cells, it is inhibiting. Okay, but this granule parallel fibers, okay, in the cortex, okay, cerebellar cortex, it goes and it stimulates everyone. Okay, so this inhibiting this Purkinje cells. So at the end of the day, the main thing is that we need an output. Okay, so the main thing is we need an output, and to get that output, see how does the cerebellar output come? That is from the cortex via Purkinje cells. It goes and stimulates the deep nucleus. That goes via superior cerebellar peduncle and goes to the contralateral cortex. Okay, so what was happening there? Middle cerebellar peduncle was bringing information from the contralateral cortex, while inferior cerebellar peduncle was bringing information from spinal cord. Means we can say spinocerebellar tract is coming via inferior cerebellar peduncle. Okay, and obviously vestibulocochlear pathway also here. So the main thing, the final this thing is we have to somehow stimulate this Purkinje cells, which in turn, we have to somehow stimulate this deep nucleus, which in turn will take the connection from cerebellar peduncle to the contralateral cortex. So my main objective here needs to be deep cerebellar nucleus. I have to make sure that it stimulates who? Cortex, reticular formation, red nucleus, vestibular nucleus. Okay, So that is the main thing. I need to make sure that my deep cerebellar nuclei that is taking my output, if everything is stimulated, that takes my output, that is positive. Alright. So that's why when you have the information like this coming here, okay, so for that what happens? Now we go backwards. If I need this to be positive, this negative here needs to be inhibited. Purkinje cells are inhibitory in nature. Actually, every cell in cortex is inhibitory in nature except one cell, and that is granule cell. Granule cell is excitatory and it is supplied by the mossy fibers. Okay, so Purkinje cells inhibiting. So I want this to be positive. So I will not let the Purkinje cells inhibit. So I have to inhibit the Purkinje cells. Who is going to inhibit Purkinje cells? This basket cell from lower and astrocyte or stellate cell that is high up in the sky. Okay, so who is going to this inhibitory neurons is firing at the Purkinje cells and inhibiting the Purkinje cells, because of which deep nucleus can give its output. Now, who will stimulate this? So this is stimulated basically by this granule cell, which is the only excitatory cell that is present in cerebellar cortex. Okay, and who is stimulated? Granule cells. Who is stimulating granule cells? It is the spinocerebellar tract, inferior cerebellar peduncle, parallel mossy fibers, excitatory fundamental, pons, reticular formation. Okay, next is Golgi. Golgi. Golgi is just in this feedback loop that if it becomes too much of parallel fibers, then it just goes and inhibits this, okay, granule cells, which basically forms the parallel fibers. Okay, and here also it's going to be a feedback loop. If inferior or library nucleus, it's stimulating this too much, is stimulating this also. Inferior or library nucleus goes and directly inhibits the Purkinje cells also, similar to those stars. Okay, so if it is positive, too much positive, then obviously deep nucleus goes and inhibits it. So here is one feedback loop between the inferior library, and here is another feedback loop, Golgi and granule. Okay, and yeah, all the negative inhibitors is GABA, all the inhibitory inhibitors is GABA in the CNS, and all the positive is going to be glutamate. Okay, so okay, so the next thing that we have is basal ganglia. All right. Okay. Okay, so in case of basal ganglia, what do we have? Okay, so the first thing is obviously involuntary movements and your cortical input. It provides negative feedback. Now here they had, this is also an important past INICET question where obviously they had given the order. Okay, so receives cortical input, provides negative feedback to cortex, and therefore modulates the whole this thing. So striatum, putamen. Striatum is composed of what? Putamen, that is motor, and caudate, that is cognitive. Okay, so caudate nucleus and putamen. Okay, and lentiform is going to be putamen and globus pallidus. Okay, so lentiform is putamen and globus pallidus. Okay, and striatum It's caudate and putamen. Okay, next is now we have direct and indirect pathway. Okay, so this can be usually a bit confusing. Okay, this cross section is very important. Okay, so first let's go through this cross section first. Okay, and then we go through the pathway. Okay, so first things first. Okay, so this is the mammillary body. Obviously we have the limbic system. Mammillary body is connected to the high hippocampus by which structure? That is the this thing, the fornix. Fornix is the association. Insula is obviously this. Okay, and this is going to be amygdala. These are the parts of the limbic system. Substantia nigra. Subthalamic nucleus is here. Okay, hypothalamus is here. Okay, subthalamic nucleus is here just below the thalamus. See, here is the thalamus, hypothalamus, subthalamus. Okay, that is one. Next, we have obviously the third ventricle, the thalamus. Next is the lateral ventricle, obviously the caudate nucleus, internal capsule. So this is internal capsule. Next, we have three things. Okay, here is the mammillary body, insula. Okay, three things: globus pallidus, globus externus, and internus. Okay, and then the putamen. Putamen is outer. Okay, so putamen with globus pallidus. Okay, is lentiform nucleus. So this entire thing is called lentiform nucleus. Okay, putamen with globus pallidus. Putamen with globus pallidus. Globus pallidus is called lentiform, while putamen with caudate. Okay, so this was caudate. Where was caudate? Okay, this is caudate. So far away. Putamen with caudate. Okay, that is called striatum. Okay, putamen with caudate. SPC. Okay, striatum putamen caudate. C T T T. Striatum putamen caudate. SPC, whatever. LPG. Oh, LPG cylinder. Okay, this is good. LPG. Okay, LPG cylinder. LPG cylinder, you can just burst it in the brain, basically. Like, that's obviously brutal, but then yeah. Next is excitatory pathway. Alright, so how are we going to this thing? So, direct excitatory pathway, that's going to be SNC, that's substantia nigra. Now, see this. Okay, direct pathway, this is going to be the direct pathway. So, the greenish one is going to be the direct pathway. Alright, so here what happens from the motor cortex. Okay, from the motor cortex you have, okay, so what is this? So from the motor cortex you basically have some this coming to your globus pallidus, okay, externus. Okay, so first it comes to the putamen. Okay, so from the putamen what happens is, from the putamen you have the direct and you have the indirect pathway. Okay, so usually what happens, putamen, you have direct indirect pathway. So first indirect is when it goes to the GPE, okay, globus pallidus externus, which basically secretes GABA and inhibits the thalamus. Okay, so in turn, because this inhibits the thalamus, globus pallidus internus. Okay, so and here direct pathway, it goes directly and stimulates this GPI. Okay, because it stimulates the GPI, this basically secretes GABA, goes to the thalamus. Okay, so GABA secretes the thalamus, prevents the thalamus from not stimulating cortex, and therefore keeps a check and balance. Okay, so that is important. It keeps a check and balance. Alright, so that is the direct pathway. Okay, that it directly came stimulated this, because it's stimulated, therefore this got inhibited, because this got like the direct pathway basically comes like this. Okay, that GABA, this got in. Okay, so next we have direct excitatory pathway, SNC. Inputs to the striatum, either nigrostriatum dopaminergic pathway, Okay, inputs to the striatum. This is the striatum by the nigrostriatal. This needs a better understanding actually. First aid hasn't given this very well. Okay, which inhibits GABA release from GPI. Okay, so simply put, SNAC is input to the striatum via the nigrostriatal dopaminergic pathway. This was the striatum. So via the nigrostriatal dopaminergic pathway, fine. Okay, releases GABA. So that's why this releases GABA, which basically inhibits the GABA and releases the GPI. Okay, this and releases which. So what does it do basically? So dopamine, which inhibits GABA release from the GPI. So because it is inhibiting the GABA release from the GPI, that's why there is increased motion because of indirect pathway. Because this GABA release of GPI is not happening. In the indirect pathway, SNC inputs to the striatum and then via the nigrostriatal releases GABA that disinhibits subthalamic nucleus. So that's why the stimulation is not there. Okay, this inhibits subthalamic nuclei via the GPE inhibition. Okay, and that's why, like, because this is inhibitory, right? So it prevents the inhibitory control of this, and therefore it stimulates this. And because this is more stimulated, so that's why GABA goes to the thalamus, and therefore thalamus is inhibited. Okay, so that is like we have to go back through. This is more better given in case of in this thing. Okay, that I mean this is a very important diagram, but it's better in Zainab ma'am's this thing and the following lectures. I mean the following pages. Obviously, this much you have to know. Sylvian fissure is this. Limbic system is this. Okay, and vernix area though obviously is very important. Broca's area is very important, and the most important thing is Broca's is infrafrontal. Okay, inferior frontal, while wernicke's is superior temporal. Okay, so frontal and parietal articular connected to articular fasciculus connects the two, and so on and so forth. Next is this. This is very important from surgery anesthesia point of view, and cerebral perfusion, this thing. Okay, so this is quite significant. Okay, so here we can do one thing. Okay, so what is this? Okay, so what happens is cerebral perfusion obviously is a tight autoregulation is blindly driven by PCO2. So very important. It is cerebral perfusion is mainly mediated by PCO2. There is going to be severe hypoxia. Okay, it releases a pressure gradient. Okay, so it also relies on a pressure gradient between mean arterial pressure and intracranial pressure. Okay, so here what happens? You have a mean arterial pressure and you have a mean arterial pressure and you have intracranial pressure. Okay, so what happens is obviously PO2 modulates perfusion only in case of severe hypoxia, but most of the time it is PCO2. Now the most important thing, decrease blood pressure or increase ICP. Okay, decrease BP or increase ICP, it decreases the cerebral perfusion pressure. So decreased blood pressure, if you have decreased pressure or if you have raised ICP, because ICP ultimately is equal to what? ICP is equals to, okay, you have the CCP. Okay, cerebral perfusion pressure is ultimately equal to MAP minus ICP. So MAP, if ICP is increased or this is or your blood pressure is decreased, then ultimately cerebral perfusion pressure also decreases. So what is Cushing's reflex? Hypertension, bradycardia, respiratory depression in response to increased ICP. Okay, this is important. Cushing reflex is triad of hypertension, bradycardia, respiratory. Hypertension, bradycardia, respiratory depression. Triad of hypertension, bradycardia, respiratory depression. After this, I'm going to GIT. Okay, because I'm feeling quite sleepy and neuro shouldn't be done in a very sleepy state. So triad of hypertension, bradycardia, respiratory depression in response to ICP. So therapeutic hyperventilation, what happens? Hyperventilation means decrease PCO2. Because of that you get vasoconstriction And because obviously PCO2 is like the vasodilator, it is like in the presence of PCO2, okay, you it is basically that those are like locals, this thing. So decreased PCO2 causes vasoconstriction, okay, because it causes vasoconstriction, that's why it decreases the cerebral blood flow, okay. So it decreases the cerebral blood flow and therefore it decreases ICP. So if this decreases, obviously cerebral perfusion pressure automatically increases. Okay, so it may be used in treatment of acute cerebral edema, secondary to stroke, that are unresponsive to any other intervention. Okay, next, no cerebral perfusion, brain death. Next is hypoxemia increases CPP. Okay, next we spoke about PCO2. We spoke about PCO2 therapeutic ventilation, how it causes constriction and how it is decreasing the ICP, and because of it is increasing the cerebral perfusion pressure. So here we basically have hypoxemia increases CPP only if PO2 is going to be less than 50. So it has to go to a significant value, that is less than 50. Less than 50 severe hypoxia, then it is going to be CPP. Okay, then it's going to increase the cerebral perfusion pressure. CPP is directly proportional to partial pressure of carbon dioxide until partial pressure carbon dioxide more than 90. Okay, so the more you decrease, okay, so basically they're trying to say is partial pressure of carbon dioxide, decrease in partial pressure of carbon dioxide is going to decrease the ICP, so it's going to decrease the ICP. So basically that we are trying to say directly proportional means it goes on decreasing, so until the PCO2 is more than 90. Now look at this. Okay, this is hypoxemia. Okay, here we're increasing, say hypoxemia increases CCP only if it is less than this. See, it is going down. The moment it has 50, then MAP is dependent on is sensing this PO2 and therefore increasing. Okay, and here what happens is you increase the partial pressure of carbon dioxide. Okay, and because of that there will be mean arterial pressure will increase. Okay, so you increase the carbon dioxide, mean arterial pressure is going to increase, this is going to increase. Okay, if this increases then the CPP will also increase. So that's CPP. So this is what it means. CPP is directly proportional to PCO2 until PCO2 is more than 90. After that it basically reaches a plateau. Okay, now this particular this is significant because of only one reason, and that is because the most important thing about this topographic Wernicke's Broca's and Wernicke's, okay, always MCA yeah. The most important this thing is simply that what do you have? You have all the legs and all that is medially, okay, and all mouth and everything, fingers, it just goes laterally, right? So that is done, okay. So here what do you have? Okay, when anything happens this side medially, okay, so obviously you'll have hemiplegia, okay, and then there'll be bladder and stuff also, because here you have one region controlling exactly that. So brainstem, whenever the brainstem is going to cross hemiplegia, okay, brainstem is going to cross hemiplegia, fine, okay, and you can go laugh, you laugh, LAF if you want to demonic for this. So L is going to be leg, A is going to be arm, and F is going to be face. Okay, medial most is going to be anterior cerebral artery. Middle, your middle portion is middle cerebral artery, and the posterior most mainly the temporal lobe and so on, and the deeper structures. This is going to be posterior cerebral artery. Okay, so this only if you want to that you looked at this thing. If you want to look at it medially, obviously the posterior most is going to, this is the anterior portion, the posterior most is going to posterior cerebral artery. Okay, mainly temporal lobe and everything is going to be middle, parietal and frontal, and absolutely frontal and anteromedial. Anteromedial, okay. Frontal, see, not just frontal but also medial. See, medial portion you have such a high amount of middle anterior cerebral artery also is quite good. Okay, see this entire this thing, not this part, this is anterior. Okay, so it's very obvious when you have the lateral surface, the entire lateral surface is supplied a lot by the middle cerebral artery. Like you can see here, the entire lateral surface is supplied a lot. So lateral surface has a lot of things. It has motor, sensory, Broca's, Wernicke's. All this is in the lateral side. Okay, so that is going to be frontal and parietal, middle cerebral. Posterior is simply the brainstem and the occipital lobe. So that is posterior. And now you come to see, posterior is more of, see, so much of the occipital lobe is posterior, so we have more importance here. Okay, so that is done. Okay, so lateral surface we understood. Now medial is all anterior. Medial is all anterior. Okay, frontal and anteromedial. Okay, here that's why posterior is occupying so much, while middle is mainly lateral. So therefore it is just a small portion here. In the same way here, okay, all the middle part was lateral, while all the medial here is going to be anterior, but we don't see a lot of medial. We are most of the medial is covered up by this occipital lobe, which is supplied by the posterior cerebral artery. Next, watershed zones. Okay, so cortical zones occur between your anterior cortical body, anterior and middle. Okay, so think of this. This is anterior, while this is middle. Maybe this will have a cortical zone. So uh, what happens between anterior and middle cerebral artery and posterior and middle, obviously middle cerebral artery is at the center of everything, so that's why you have borders with this, it shares borders with that, and it shares borders with this and this. So obviously here we have posterior and middle. Okay, so posterior and middle is here. Okay, and anterior and middle is here. Now, internal border zones occur between superficial and deep vascular territory and the middle cerebral artery only. Okay, so internal zones, it's all middle cerebral artery, superficial and deep. Now, most common location of brainstem metastasis. Okay, locations, infarct due to severe hypoperfusion. Okay, so when you have ACA, MCA, okay, ACMC is mainly front. Okay, so proximal and upper lower limb weakness. Okay, man in a barrel syndrome. Okay, so basic thing is obviously the motor cortex is in front. Okay, so obviously that. Next is PCMC is higher order visual dysfunction because posterior is not visual. Okay, so I think we are good to go. This is also okay. Okay, this was another one. Okay, I have taken thumbs or notes. Okay, this is PCA is back. Okay, PCA ka deep branches is here. MCA division not necessary. Anterior choroidal artery is just here. Okay, that is your ICA, which is supplied with the ICA is posterior limb. Okay, then you have MCA deep branches and superior division ACA branches. Okay, so MCA superior division is the ventricular striate branch, and then you have ACA. Okay, and here is this lenticular striate branch. Lacunar infarct is very important. Thalamus, it caused the Jerin-Ducy syndrome something. Okay, so here you have M1. Okay, this is MCA ka, so MCA ka M1. Okay, then you have M2 is this hook. Then you have when it's coming out from the insula is M3. I mean this hook is M2, and then this upward bending, this downward bending is M2, upward bending is M3, and then after that when you come out then it's going to be M4. So superior division, okay, that is M4, and inferior division is M3 is the superior division and M4 is the inferior division. It gives penetrating branches, lenticular and lacunar infarct. Okay, so this is done. This is done anterior choroidal artery, VCA, internal capsule. Okay, next we have is this. Okay, so circle of Willis is very important. Okay, but then more important than this particular diagram, Xenon had given, that was an even better one. Okay, see posterior circulation is the fine. Okay, just this much. Remember that pica is going like this, and then after that it is joining and it is forming the basilar artery, and then this is divided into posterior cerebral artery. Ica is a branch of the basilar artery, while pica is a branch of the vertebral artery. Okay, so P1 and P2, that's posterior cerebral artery. The P1 part is midbrain and the P2 part goes to the occipital region. Okay, then after that we have the internal carotid artery, which basically gives on the lenticular striatal artery. This is C. This is dividing into 2, 3. This is middle cerebral artery, lenticular striate, optic chiasma, medial surface, middle cerebral artery, anterior communicating artery. Oblique lateral view, all this is fine. Okay, next we come to dural venous sinuses. Now, this is a PGI question, that what drains into the cavernous sinus, and that is going to be superior ophthalmic vein and sphenoparietal sinus. Okay, so this is PGI. Okay, next is large venous channel that run through the periosteal meningeal layer of the dura. So basically periosteal meningeal layer of the dura, so all these epical stuff. Drain blood from this is arachnoid granulations. Okay, empty into the internal jugular vein, that's absolutely okay. Presents venous thrombosis, raised ICP, headache, seizure, papilledema, focal neurological defects, factor Leiden deficiency, OCP use, pregnancy. Okay, and now jugular foramen, this will go the confluence of sinus. Confluence of sinus is formed by cell. Then you have the straight sinus, you have the and inferior and distinct sinus. Okay, you have the superior sagittal sinus, you have the straight sinus, you have the two distinct sinus. Okay, two sigmoid sinuses, and then you have the transverse sinus, occipital sinus, and all of this also. So yeah, okay, great cerebral vein of Galen. Okay, inferior sagittal sinus, superior sagittal sinus. This is going down like this. Okay, and these three are very important. Superior ophthalmic sphenoparietal, superior ophthalmic sphenoparietal sinus, and cavernous sinus. Very, very, very important. Okay, okay. So this one we'll leave it for tomorrow. Okay, because I'm extremely sleepy and it's better to do something else rather than neuro. Okay, when you're like this. Okay, so we'll do another system in the next video and continue with neuro tomorrow.